impression is a seasonal. Okay, so you can see it's a seasonal. So from time to time, it could be have a small outbreak, and then it could be influenza A, maybe H1, it could be H7, it could be H5, but generally the common one would be H1, and then we have H3 to recently, and also influenza B. Okay, so if you compare to the case globally, right, not only in Malaysia, we have seen the similar pattern. So as you can see, that's why it's kind of like a small epidemic outbreak. So when you see case like this, right, we can know that there are currently influenza increasing, and then we need to take precaution, whether taking the flu shot or whether we need to go for prevention, wearing masks or better precautions to prevent you from infected by flu. Okay, so let's have a better overview of the influenza virus. So this is a picture of the influenza. Okay, you can see there are a lot of surface receptor on top. Okay, so basically this is an envelope virus. Okay, so the envelope virus is a bit more vulnerable to the environment, so it's not like the non-envelope one. Okay, still it can easily degraded with the ethanol, those kind of the antiviral treatment. Okay, and then you can go, this is also the single-stranded RNA virus. That means it's a single-stranded and it's prone to mutation, so it can be easily mutated. Okay, so it's under automysoviral family, and it causes majority of the viral upper and lower respiratory tract infection. Not only the upper, but go to the lower, that go to the lung section. And the common type for the influenza will be type A, B, C, and D. Okay, and generally it causes a seasonal epidemic of disease. So we normally call it as a flu season, right? So here are type A, B, C, and D. So A and B is the most common one. Okay, so A can be further further classified into the subtype according to the combination of the hemagglutinin and also the neuraminidase and HA and NA. These are the protein on the surface of the virus. So the most currently circulating, right, globally is known as H1N1 and also H3N2. These are the influenza virus. And only influenza type A virus are known to have a cause pandemic. Okay, so influenza B virus are also is not classified into any subtypes, but can be broken down into lineage. So the current one is most common is the Beta or Yamagata, okay, or Victoria lineage. So the third one is the influenza C. Okay, it's very less, it's infrequent. Okay, so you don't really see influenza C in the health public. And for influenza D is currently only affect cattle. Okay, that means it's not known to infect any human being. Okay, so the common one will be influenza A and B. Okay, so there's a nice cute poster from the NIH, and NIH you can see, right, that these are the season in Malaysia, commonly the outbreak of the influenza. So normally in the early of the year or in the mid. So currently actually we are in the outbreak, but seems like we are at the end of the outbreak of influenza B. Okay, so what are the signs, symptoms, and also the transmitted route of the influenza virus? Okay, cause of the high, normally influenza virus cause of high morbidity and mortality worldwide, considering the elderly and also the compromised individual are especially at risk of developing the severe illness and complications such as pneumonia. So this is why it compared to the cold, right? So influenza and also the cold, flu versus cold. So cold normally we can get sick, but normally we can recover better. But for flu, right, there are risks, especially for the elderly and also the younger. They might go for the serious complication, the acute disease like pneumonia. Okay, the most common symptom will be fever, there'll be chill, cough, normally dry one, and the muscle and joint pain, have sore throat, runny nose, headache, and also anorexia. Okay, the influenza virus generally spread like COVID is from person to person through the air in the droplet. Okay, when you sneeze, you cough. So when you sneeze, you cough, you need to cover with your cloth, okay, or with your hands to prevent a direct spread of the droplet. And also it can be all by indirect contact. So indirect contact, that means if you have sneezed to a certain surface, right? If you touch the surface, if for example the escalator handle, and then someone touch it, and then they touch their mouth, nose, and then you will get infected also. So that's the indirect contact, through direct or indirect. or in terms of the epidemiology, okay, all age group can be affected, but there are group that are more risk than others. Okay, as I mentioned earlier, so those who are at greater risk are normally the pregnant women, children under 59 months, the elderly, or those individuals with a chronic medical condition like chronic cardiac, pulmonary, renal, metabolic, and also those individuals with the immunosuppressive condition, such as those infected with the HIV or receive chemotherapy or steroid. Okay. So in terms of transmission, right? So normally in the seasonal flu, it can spread easily, especially at the right temperature, right condition, and also in the crowded area such as school and nursing home. So sometimes when you see this outbreak, right, it's mostly happen in the hospital, and then in the school area, and also in some other nursing home. Okay. Okay. So in terms of the diagnosis, right, how do you diagnose? Okay, so those are the cases you will get the cases of the infected, and then but how do you know whether this is the influenza or whether this is the cold, is the common cold, is by other type of virus or other type of bacteria? Okay, so the infection could be by flu, it could be by other respiratory virus, for example, rhinovirus, RSV, and also adenovirus, etc. These are all present as an influenza-like illness. The symptoms are closely, they are alike. Okay, so in making the clinical differentiation of the influenza from other pathogens is very difficult. Okay, how the lab can do the confirmation is normally through you get the sample swab from the throat, from the nasal, and also for the nasopharyngeal, or could be tracheal spread. Okay, it's quite common also to using the direct antigen detection. That's mean using the rapid test kit, or you can isolate the virus, you go for the culture, and the last one, it could be go for the qPCR. Okay, real-time reverse transcription, real-time qPCR technique is a more sensitive method. So either RTK or go to real-time qPCR method. Okay, this is the most common method currently using in all the labs. Okay. So after you diagnose, right, you are being identified. So what are the treatment? It should be given to those infected. So basically you divide into two part of people, two groups. The first group, right, you are infected, but you don't have any kind of complicated, okay, symptom. So those are not from the high risk group. So those are the healthy adult. Okay, normally you based on the symptom and then you go for treatment. Okay, if there is a minimum treatment, right, basically, right, what you do is you stay at home, you rest, get enough of rest. So the treatment is focused on the relieving the symptom of the influenza, such as if you are fever, right, then you take Panadol. Okay, you get more rest, drink more water. Okay, patients should monitor themselves to detect if the condition deteriorate, and in case, right, they're having some difficulty improving. Okay, you need to seek for the medical attention. Okay, so based on the symptom, and then doctor will prescribe with the antiviral drugs if needed. Okay, the second group of the patient is those with the severe clinical illness or those who are known to be at risk. Okay, so example of the clinical syndrome could be pneumonia, sepsis, okay, exacerbation of chronic underlying disease. This should be treated with the antiviral drug directly. Okay, so the common drug will be neuraminidase inhibitor. So this is a very common drug. Okay, it can be prescribed as soon as possible, ideally within the 48 hours following the symptom onset to maximize the therapeutic outcome. Okay, the function of the neuraminidase inhibitor is to prevent the fusion. Okay, it prevent the budding and also the fusion, so that the virus won't be replicating. Okay, we also have the cortisol steroid. Okay, can be used. Okay, not suitable for those with the asthma. Okay, this the function of this drug is to clear, okay, to prevent the replication also. Okay, and so it helps to suppress the inflammation. Okay, so reduce the symptom. Okay, and most of the current circulating influenza virus, right, it could be resistant to the adamantine antiviral drugs. Okay, so it's not recommended to have a monotherapy. If you go for treatment, right, maybe you need to have two drugs, two different types of the MOA together. Okay. So then lastly for the prevention. So as you know that prevention is better than cure. Okay, so instead of we get infected, right, the best way to prevent the disease is through one of the way is through vaccination. Okay, so when you know that you're gonna be have a season, and then you need to get the flu shot from the clinic, and then depends on the particular season, right? Sometimes it's a season, it's a flu A, it's a flu B. Okay, so you get a good more directed shot of that particular flu A or flu B. Okay, so the injected inactivated influenza vaccine is the most common way used throughout the world. Okay, among the healthy adult, right, influenza vaccine provide protection even when the circulating virus is not exactly matching the vaccine virus. So in case you get the shot for the flu A, right, still you have some little protection from flu B also. Okay, vaccination is especially important for the people at high risk of influenza competition, and for those people who live with or care for those people at high risk. So one of the way is through vaccination. Okay. Secondly, you can just based on this KKM guideline, what you need to do is always prevent for it. Okay. So vaccine, and then always cover your mouth and nose. The most common things to do and follow. Wear mask, okay, during the spread of the influenza. But currently, since it's a COVID pandemic, currently it's not an epidemic, so still you are wearing the mask. So the prevention is same exactly like the one we are facing right now. Okay, if you have a serious symptom, go for the treatment. Okay, or you are at risk, go for doctors. Okay, so far, do you have any question currently? Okay, if no, I will share with you about this system in Malaysia. Okay, Malaysia got one system is known as the Malaysia Influenza Surveillance System. The purpose of this system is to survey. Okay, they need to get the data from all the clinic, and then they need to report whether there's could be an outbreak, okay, of the influenza. Okay, so generally, right, for the acute respiratory infection, right, it can divide into two types. First of the type is the influenza-like illness. Second one is the case lead to the severe acute respiratory infection. Sorry. Okay. So in general, right, in the primary care, in the clinic or the outpatient setting, right, those who are measured with fever more than 38 degrees and with cough, and those with the onset within last 10 days, right, should go for diagnostic. Okay, should be tested for whether it's influenza or other respiratory infection. Okay, and then the second case is those need hospitalization. Okay, same symptom, but they require hospitalization. This is known as a SARI case. Okay, so how do you collect the sample? So if the doctor identified the guys as ELI or the SARI case, right? For the ELI case, normally you can get the nasopharyngeal swab, you can get the throat swab, or you can get the sputum. So these are the three common specimen type. Okay, for the swab, normally you use the VTM or UTM. Okay, and the second one, if they're using a sputum, it can get inside the sterile container. Transport to the designated laboratory within 48 hours using the cold blocks. Okay. In terms for SARI, right, the same specimen type as the ELI case, but in addition, you can get some more like BAL, trachea aspirate, endotracheal tubes aspiration also. These can be obtained. And then the same time, you need to deliver to the lab. Okay. From the clinic, you deliver to the lab within 48 hours in ice box. Okay, this is the sample collection. And then how do you pack it? Because these are normally assigned for those particular clinic. Okay, if the clinic, they want to send the sample, right, after they do the packaging, collect the sample in the sterile container or VTM. Okay, they need to label the sample with the patient ID, patient name, sample type, date of the sample collection, and then place the sample individual in the biohazard plastic bag, put the sample into the cool box, seal it, and transport to the diagnostic lab, okay, as soon as possible. Okay, and then you need to go for the testing. Now it depends on the lab. So currently, they don't have a specific guideline which particular kit, which particular technique can be used. So in general, right, still you can go for the cell culture technique to isolate the virus Okay, also go for the HAI assay, but this will be time consuming, very much time consuming. So currently, commonly will be still using the RDK. If not, otherwise they go for the molecular technique, especially they go for the central lab, because the molecular technique can diagnose for more different kind of the respiratory virus, and it's more easily to use, it's more sensitive. So as you can see, right, in the past, right, since the 2009, so since there's a pandemic of H1N1, right, most of the lab currently they are using the real-time PCR technique, the platform for most of the diagnostic lab. Okay, this is the Malaysia influenza surveillance system, but depends on the lab. A lot of private lab, they have their own rules and regulation for the specimen collection and also the treatment. Okay, so apart from the flu, right, this one, and I need to highlight also, if you can see, right, this is the respiratory infection in Malaysia. Okay, the study is conducted on the children aged 0 to 5 years old with the ARTR, the acute respiratory tract infection, was seen in the pediatric in Kuala Lumpur hospital. Okay, so the sample was sent and diagnosed. So this is quite some time ago in 2014 and 2015. So if you can see the distribution, right? So you can see there's a season of the most getting cold or flu here around May time. Okay, there are sometime in August. And then these are all the virus, the infection agent. Very common one is the enterovirus and also the rhinovirus. Okay, HRV. Secondly is the RSV. Then we have the adenovirus, metapneumovirus, Boca virus. Then here come the influenza. So they don't have much outbreak here during that time. There's also parainfluenza virus and also coronavirus. So not only influenza, so it could be infected by other virus also. Okay. And then there's another study. Okay. This is a nasopharyngeal swab. Okay. Received at 12 different laboratories located at different states in Malaysia from January 2015 to 2019. Okay. Swab sample were collected from pediatric in and outpatient, those who are less than 18 years old, with the sign of the symptom of respiratory tract infection, including running and stuffy nose, sore throat, cough, chills, fatigue, and muscle ache. So similar pattern you can see here. So first of all is the rhinovirus. There will be respiratory syncytial virus, RSV, also influenza A, and then adenovirus, parainfluenza, and influenza B. There are metapneumovirus and also the coronavirus. Okay, a number of different kind of virus, and the treatment for the virus could be different. So as you can see, these are the most common virus, the rhinovirus. So rhinovirus, enterovirus, and also other adenovirus, right? We normally call them as a cold instead of flu. So you can see this is the flyer from the CDC, whether it's a cold or it's a flu. Okay, flu is generally referred to the influenza infection, and the cold, it could be others similar respiratory with the chill-like symptom with fever. This is the normally known as cold. Okay, the symptom for the cold and flu is normally the symptom for the cold is gradually, but the flu is suddenly you just get more severe. Okay, it's more erupted one. Then fever is normally cold, normally you just have a runny nose. It's rarely to have fever. And then the flu one is normally you used to have fever. Okay, and then the chill is uncommon, common, you can get fatigue, and the cold is normally you get the sneezing. Okay, stuffy nose, sore throat is more common to cold rather than flu. Okay, so these are different. So for the HRV and enterovirus, right, both are family from the enterovirus, family of the picornavirus. So estimated about 50% of the common cold are caused by the same kind of rhinovirus. Okay, the infections are normally of your nose. It's only at the upper part. Okay, and it's quite frequently affect the children, especially the newborn baby. Okay, and generally it's related to the respiratory tract infection and transmit through aerosol in the respiratory droplet and also from mites. Okay, in contrast to the HIV, right, HIV enterovirus is lesser, but also can take infection in the respiratory, and at the same time can be through fecal oral route. That means it can through the intestine also to other organ. So HIV, right, infection can be more severe, causing the poliomyelitis, meningitis, infection in brain, and then also some other part in the body, okay, in the eyes, etc. Okay, apart from using the normal respiratory swab, they can use the CSF, blood, or stool is commonly used for HIV. Then we also have this RSV, okay, very common in the overseas country, okay. For those newborn baby, right, first of all, right, they need to test for RSV, okay. It's very common there, and then it can cause the bronchitis, pneumonia also in severe case, okay. So they have some similar symptom like flu also. There's a cough, sore throat, headache, okay. RSV is generally transmitted through a large nasopharyngeal secretion droplet from the infected individual. Those close contact or you are touching the indirect contact also will be happening also, okay. So it can be last long in the surface. And then there are more like adenovirus, metapneumovirus, and Boca virus. Okay, these are quite, we are getting more and more this kind of different kind of virus. So correctly identify the virus infection, right, is quite critical before the doctor giving the prescription whether to treat with the drug or not. Because sometimes if you overtreat, right, it might lead to the antiviral resistant development. Okay, so seeing all of the respiratory infection, right, they have the similar clinical symptom. The diagnosis of this virus or bacteria is traditionally using the culture method of serology, but currently more and more people using real-time PCR, as it's a more sensitive method and it's fast also. You can get the result within a few hours, okay? Right. So what actually we can offer you in terms of this is, let me give you a short briefing of our company, okay? So we established in 1978 in the Science Berhad. We are the medical equipment and service provider for entire Malaysia. We have ISO 9001 certified, and then we are GDPMD compliance. So this is our office in Shah Alam. Okay, we cover a lot of brand for the laboratory instrument, Azo, Vicks, Syngene. They are Promega for extraction. Okay, these are more items like Abbott for the molecular detection. We have the Certest, Living Bio for RTK kits. All right. We also do the setup of the lab, and together from my side, we are from the application team. We conduct the training, troubleshooting in case you need our help for it. Okay, and then the Certest kit we are supplying. So Certest is from the SPAN. So their main activity is develop and distribute the diagnostic kit. Okay. So all the kit is the CE-IVD mark, and then the qualification is using the ISO 13485. The aim of the Certest Biotech is to give a full, complete solution for the clinical diagnostics. Okay, high sensitivity, high specificity, and highly reproducibility. Okay, so in the Viastro kit, right, we can not only detect the respiratory infection, we also have the kit to detect the sexual health disease, tropical or waterborne like the Zika, dengue, chikungunya, and monkeypox also. Then we have the antimicrobial resistant gastrointestinal infection, a lot of different kind of panels. So the one our focus is about the respiratory currently. Okay, so we have the M to simplify the real-time PCR diagnostic. The kit should be easy to use, stable, reliable, and also versatile. All right. So all our kit, right, we are using the lyophilized reagent. Okay, the reagent are all of the chemical, right, the polymerase, the reverse transcriptase, DNTPs, buffer additive are all lyophilized and mixed inside the tubes like this. Okay, so this is our reagent. So we make the things easier, so the things can be transported and stored in the room temperature, and then the shelf life is 24 months. It can last long, so you don't need to worry about how long it can be kept. And most of the assays we are using the standardized protocol. Okay, that means the temperature of the denaturing annealing are all fixed. So you can run different assays at the same time. So you can run the gastro panel, you can run the respiratory panel, sexual health panel, all in the same run. Okay. And then how do you use it? So since it's lyophilized, what you need to do is you add 50 microliter of the buffer supply, and then add 5 microliter of the extracted nucleic acid. It could be DNA, RNA, and then you just load it into the thermocycler, and then you analyze the result. Very straightforward. You don't need to prepare for the mass mix. Okay, and then we do provide a different kind of the tube format. They are low, they are strip profile, high strip profile, and then there's a tube version for those cases, you need to go for the automated liquid handling or using the rotogene tubes. Okay. And if tested on a lot of real-time PCR system, the common one like the Agilent, the Applied Bio system, Bio-Rad, Roche system, okay, high profile, low profile, these are all validated. All right. In terms of the kit, right, we supply 3 different formats. One is the monoplex. In case the lab only want to detect particular virus, right, do not want to go for multiplex. We have the monoplex kit. These are the choices, okay. The Boca virus, influenza, RSV, okay, the pneumocystis, DRVC, very common, MTC, the Mycobacterium tuberculosis, and then we also have the multiplex. Multiplex means several targets in the same tubes or 2 different tubes. Then we also have a most commonly used one is this flu typing. Some people want to go for flu typing. And then the common panel is like respiratory viral panel. It can detect flu A, flu B, RSV, and also the typing together. Okay. These are a number of cases, okay, a number of different kits to choose, depends on the lab requirement or depends on the incident, okay, how frequent you are getting the infections in that particular area. Okay. Okay. And then we have also for the SARS-CoV. Currently, it's a SARS-CoV and SARS-CoV pandemic. So we have the kit for the SARS-CoV to detect RFID engines, and then there's a variant detection. So we do provide the kit also for SARS-CoV detection, variant detection, and combination of the SARS-CoV, flu, and RSV. Okay, because some want to differentiate. Okay, I know in some laboratory, right, they start to use the multiplex like this, detect SARS-CoV or flu A, flu B, because they want to differentiate. In case they are going for the flu, right? Okay, those are identified flu, right? They will straight go for the antiviral treatment for those younger children. So they need to know it. Otherwise, right, sometimes they cannot give the proper treatment. Okay. Apart from the multiplex, we do have a bigger panel. So normally we know as this, we call it as a panel kit. Not only 4 target or etc. We can go for 10 plus target. Okay. We have different panel here in Certest, and then the most commonly used one is RP1 and RP3. Okay, RP1 can detect the adenovirus, metapneumovirus, Mocha virus, the one you see in the publication, the most common virus you can obtain in Malaysia or globally. Coronavirus, flu A, flu B, RSV, MERS-CoV, and then parainfluenza, rhinovirus, and enterovirus. Okay, this is the panel. You can also combine with the SARS-CoV virus also, in case you need it. So the kit is like this, is by panel. Okay, so the buffer is added to all the wells, and then we add in the sample, and then we straight away go for the run. Okay, so the design. So in total, 18 pathogens can be taken for the respiratory panel 1. Okay. So depends on the lab requirement. Again, you can pick, choose and mix and match. So for certain, right, you don't need this. You can pick only a certain virus, certain detection. For example, the MERS-CoV is a seasonal. For those who are returned from the Mecca and maybe need to go for the MERS-CoV. So you only need flu A, flu B, the rhinovirus and the most common one, you can pick the particular panel. So no need to go for the full panel also. All right. So that's a summary for the kit supplied by Certest. Okay, we use the same thermocycling protocol. That's why you can create your own panel. It's all lyophilized. So forget about the cold chain, everything can be stored. So you don't need to have a lot of cold storage. Ready to use and easy to use. Very long-term stability, 24 months, and can run even you don't need to batch up also. You can run 1 up to 96 sample per asset. Okay. And we also provide the nucleic acid extraction in case you need it, automated or manual kit. And then we also have a real-time PCR system supplied by our company. We have the Azo Silo 6 real-time PCR system, a very sensitive real-time PCR machine. And then, yep, that should be it from my presentation. So I've covered the introduction to the flu, okay, the detection, the symptom, all those kind of transmission, epidemiology. And at the end, the detection using the real-time PCR system covered by our company from the Certest product. So thank you. Any questions so far? Okay,
Fadi, I think we shall reserve the question until the end of the
Okay, okay.
because we have
Then
another.
that's it from my side.
Mm.
I will stop sharing.
Yes, Mr. Fu, you can stop sharing. Thank you so much for our for the presentation for today. So basically, without further ado, I would like to invite Dr. Nur Hidayah for our influenza update regarding the tests in our hospital.
Okay, thank you
Please
very much.
welcome.
Thank you, Mr. Fu, for the extensive introduction on virology and epidemiology as well as diagnostic tests available for influenza and together with other respiratory virus. So I will continue by focusing specifically on influenza virus laboratory detection at SUSMEC at IIUM. All right. So at certain point, I know I think the audience now should have the knowledge that influenza at a certain point can be a clinical diagnosis, especially in an outpatient setting, particularly when prevalence of influenza is increased within the particular community. And however, if the patient is suspected of having an influenza and require hospital admission, then testing is very much recommended, especially if you are talking about high-risk patient, immunocompromised patient, patient with worsening comorbidities, or all those vulnerable patients such as pregnant women or children. However, antiviral treatment, when it is indicated, it should not be delayed, okay? Because test itself may take time for result to be produced. And this treatment should not be delayed. If you are attending a patient, you highly suspect of having influenza, and on top of that, there are high-risk patients. So you should not delay antiviral treatment if it is indicated. In terms of the role of influenza virus testing, this one also, I think Mr. Fu has already touched about it during his presentation. Basically, the main role of testing is to inform the clinical management, whether to start or not to start antiviral treatment. And you need to exclude influenza for you to decide on further testing. If you are looking into the cause of the respiratory infection other than influenza. And on top of that, if you are planning for implementation of infection prevention and control measures, you need to confirm what is the pathogen responsible for that particular situation or outbreak, so that appropriate infection control measures can be planned. And also on top of that, testing is also crucial to determine whether it is an influenza outbreak or not. Okay, this is the algorithm by IDSA in terms of whether to test or not to test. Okay, basically, of course, in hospital setting, you have a patient with signs and symptoms suggestive of influenza, and you are planned for patient's admission, then testing is a requirement. And on top of that, if the patient does not have basically sign and symptom of influenza, look for these atypical sign and symptoms, because some patient might present atypically, unexplained fever or even afebrile with any respiratory symptom in high-risk patient. You should have a lower threshold to do testing. And on top of that, if it change your management, of course, you should proceed with testing. Okay. If it is no, then influenza testing may not be considered, and you should also consider other etiology. All right. Okay, test at SUSMEC and IIUM, basically it's conducted at medical microbiology lab, and we accept sample from, of course, from our patient in SUSMEC and IIUM, and on top of that, we also accept specimen from FAC and IMSC. For the past few weeks, I did receive questions whether they can walk in to send samples for testing in our lab, which is not appropriate. You should first need to be seen by the doctors, and if the doctors thinks that the test is indicated, then specimen collection should be taken by the doctor or the paramedics involved in managing the patient so that we can proceed with further testing. All right, so in terms of virus testing available, we have antigen detection test. And on top of that, we have also molecular assay to detect influenza. In terms of antigen, we have the rapid influenza diagnostic test, the rapid flu. And for the molecular assay, there are basically a few options of performing molecular assay, but the ones that we have in our lab is the PCR for respiratory pathogen panel. The panel consists of influenza virus, I think parainfluenza, RSV, and on top of that, we have also adenovirus, metapneumovirus, and Boca virus. We don't have a monoplex influenza virus PCR, okay? A single detection of influenza virus PCR, we don't offer this one. And on top of that, we still don't have our rapid molecular assay. IDSA, for example, have already proposed the usage or recommending the usage of rapid molecular assay, but in our setting, we're still using a rapid detection test, and we do have actually a system of rapid molecular assay, but it's not yet optimized to detect influenza virus. Hopefully, in near future, we can have the kit available lah. Inshallah. And on top of that, we don't have a virus culture, but virus culture is a very good influenza virus diagnostic testing. But in view of the time consuming test, it is not basically recommended as one of the tests to be used for diagnosis of influenza, because it may take 2 weeks, 3 weeks for the virus to grow inside the culture media. So we have our rapid influenza diagnostic kit, and we have a multiplex PCR for respiratory pathogen panel. Okay, so for rapid influenza diagnostic test, we have antigen detection. For us, we detect flu A and flu B antigen. And the test is quite fast. The test can be completed within less than 1 hour. And it has a low to moderate sensitivity. Roughly, the sensitivity is around 60 to 70%, but the specificity is very high, more than 95%. And on top of that, we have this one, multiplex molecular assay. And the test will take around 1 to 2 hours, and it is a very sensitive test, and it is highly specific. Okay, all right. So when is the most suitable time for you to conduct a sample collection? Okay, basically the rule is to take the sample as close to illness onset as possible. Because if we're referring to this graph, we have here days of infection. This is the onset of exposure. I think the y-axis is the viral load. So as we can see here, the antigen level and the RNA level is highest at the earliest stage of the illness, preferably or the most ideal sample to be taken is between 48 to 72 hours. The maximum is 72 hours for you to have a good yield on testing. If beyond 3 days of illness, the yield will be compromised. Maksudnya, the chance of you to get a positive results may be reduced. Okay, on top of that, there is also a form of antibody response can be measured, but in terms of detection of influenza antibody, is not particularly recommended to use as a diagnostic test. It is more of a seroepidemiology study if you were to look for antibody response. Okay, 48 to 72 hours ideal sample collection time. Okay, with regards to the sample collection kit here in SASMAC for antigen, for rapid influenza antigen test, we have will provide the this flock swab and together with viral transport media. It has to be a flock swab, and you should not use a usual cotton swab to perform this test or for sample collection, because cotton swab have some kind of material that will inhibit the test reaction. Flock swab on top of flock swab is being used for detection because it has this high surface area, because you only take a small swab, so the area of contact of the swab stick to the surface of the nasopharynx, for example, or the nasal or the throat should be maximized as much as possible. Okay, so once sample is being collected, it should be filled inside this. It should be deep inside this VTM, and it should be transferred to the lab immediately. And for the rapid antigen test detection, you can also provide the sample within a sterile container if the sample is in an aspirate form or fluid form. Okay. The sample ideally should arrive at integrated lab counter within 2 hours after collection. If more than 2 hours, the quality of or the integrity of the sample can be compromised, and it should be transferred under room temperature. During working hours, testing will be done immediately. Okay, and if delay in processing is anticipated, it should be stored at 2 to 8 degrees Celsius, and the sample may last for 1 to 2 days. The storage should be done inside the lab. You cannot store the sample yourself. Once sample is being collected, immediately it needs to be sent to the lab. Okay, for the collection kit or for the RPP, okay, you have this box as a secondary container. You have the VTM, the swab. Okay, basically this looks similar like COVID collection kits, right? Okay, but mind you, you should not use RPP collection kit to collect a COVID-19 specimen, and you cannot use COVID-19 collection kit to collect specimen for RPP, because once this box arrive at the lab, the processing is different. Okay, so COVID box, when it is labeled as COVID box, it implies that the staff need to prepare themselves to process the specimen in terms of wear appropriate PPE and so on. All right. Okay, on top of the VTM, you can also put fluid specimen inside a sterile container, especially for intubated patient where you need to wanted to provide endotracheal aspirate or bronchoalveolar lavage fluid. Okay, once sample is being collected, it should be transferred to the integrated lab counter immediately and on ice. Make sure the box have ice. And in terms of test frequency, it is conducted once per week. And if delay in processing is anticipated, the sample can be stored at a chiller and it will last for 5 days or at -70 if we want it to last longer, more than 5 days. Okay, the specimen of choice. You have the choice of giving us an upper respiratory tract specimen or lower respiratory tract specimen. I think most of the time here we are using this upper respiratory tract specimen. So we have a nasopharyngeal specimen. The specimen can be given in a form of aspirate and in a form of nasopharyngeal swab. You can also provide a nasal swab or throat swab. In terms of the chance to get a positive yield, highest is by you providing us the nasopharyngeal aspirate. Second option is the swab. The throat swab is the third option, which may manifest a yield which is lesser than the nasal or nasopharyngeal specimen. And if we were referring to IDSA, in order to optimize the yield, they also promote of combined throat swab. Okay. In terms of your that is not speaking, to mute your mic, please. Okay. For lower respiratory tract specimen, we have endotracheal aspirate or bronchoalveolar lavage. I think we cannot accept sputum for now because in order to process sputum, you need a special reagents for us to prepare the specimen for PCR during the extraction phase. And on top of that, do not send plasma or serum because we don't have a testing specific for plasma and serum. Okay, for upper respiratory tract, we have a nasal swab. We can do a mid-turbinate swab, nasopharyngeal swab, or throat swab. Okay, what about the test turnaround time? Okay, test turnaround time is basically the time taken for when the sample started to arrive at the microbiology lab and up until the time the result is validated in Ibersakin. For the rapid test, the TAT is 8 working hours, and for the RPP, we have 7 working days. And if the sample received outside of working hours, you should expect some kind of delay in terms of result. Okay, for interpretation of the result, you should first understand the limitation of the individual test. And the performance of the test very much depending on the quality of the specimen. Rubbish in, rubbish out. So in order to maintain the quality of specimen, the timing of sample collection should be optimized. The type of sample that you use should be the correct type of specimen. Method of collection should be appropriate. And on top of that, there's also a role of handling and processing of the sample inside the lab. And the way the staff handle the specimen may also influence the performance of the test. And on top of that, of course, the test specificity and sensitivity. And on top of that, the interpretation of influenza test result is also depending on the prevalence of the influenza among the population being tested. Okay. So in terms of the performance of tests in relation to the prevalence of influenza, in an evidence of low influenza activity, the test is very good to rule out influenza, meaning if it is negative, then most likely it is of true negative. And in an evidence of high influenza activity, the testing is very good to rule in the diagnosis. When the test result is positive, it is likely to be positive. So Mr. Fu just now have also shown this graph. Basically, we have this is basically 5 years prevalence pattern of influenza at this region, which includes Malaysia, and we are definitely in the influenza season right now, and the most predominant type or variant of influenza is influenza A H3. It has been there previously circulating, but now it is become a predominant circulating strain. Okay. All right. So as for the interpretation of the rapid influenza test results, so with regards to the sensitivity of the rapid test, it is of low to moderate sensitivity, but it is a very much highly specific virus, a specific test. And during a high influenza activity, if you get a positive results, then it is likely a true positive result. But then if you end up with a negative result, it may be a false negative result. If the patient, especially who are symptomatic or high-risk patient presented with acute respiratory infection symptom, please do not withhold treatment if you suspect that the patient is having influenza, and to confirm the result with the molecular assay. So if you do rapid antigen test and it turns out negative, but the patient is very suspect of the patient having influenza, please opt for to send a test for molecular assay. Send a sample to proceed with molecular assay. in terms of the interpretation of the molecular assay test, so we have the test is very specific and it is ultra sensitive, very sensitive. So if the results came back as positive, so it is likely true positive. Okay, no doubt. And if you end up with a negative molecular test, if you are seeing a patient that is no symptom, it may be a true negative. But there is also, you should also consider that there is a potential for false negative results, especially in a symptomatic high-risk patient. And if it happens that you first send an upper respiratory tract specimen for PCR and it came back negative, but you really suspect that the patient have influenza, you should proceed with sending a lower respiratory tract specimen for a repeat test. Okay, I think that's it from me. Sharp at 9. Okay, back to you, Fadi.
Alright, khairan kepada to Dr. Hidayah. So alright, thank you so much. As of now, so far we can proceed to our for 5 minutes Q&A session. Anyone, because there's no question in our chat box or also in the YouTube stream. Any question? We open to participant to ask any question to our speakers, Mr. Fu and also Dr.
First question, Fadi. I have question for Mr. Fu.
Okay, alright. Sure.
Mr. Fu, since currently we are seeing...
Raja kan tu bagi lepas malam kan dia off je kan ada SO nak cuti juga yang leave tu.
Sorry, Macam Mani ada soalan ke?
Sebab ada ISO.
Mic Matron.
Tak apa. Alright.
Back to the question. Since we are currently seeing a rise in influenza, what about the demand of the test? Is it very, very high that may lead to compromise in supply of test kit or how?
Currently, right, because it's actually we are concurrently having the spread of the influenza and also the SARS-CoV. So the demand actually increased. Previously, they are only focused, you have the symptom, right? You might go for the SARS-CoV, you go for RT-CAM, and then certain cases, right, still they remain as going the real-time PCR technique. But I remember go one side, right, they're saying that they need to go for the multiplex, checking the SARS-CoV together with flu, especially when flu is spreading. Because got one, I think it's a baby case, right? So they thought, at first they thought it's a SARS-CoV. So they didn't go for the antiviral therapy. So that's the reason when you see this as a suspected case, right? Currently, the tendency will go for the multiplex, SARS-CoV and flu. Yes, because especially sometimes, right, if you go for RTK, you might not detecting anything. So it's better to go for the sensitive molecular test in the multiplexing. The test requirement definitely is increasing. A lot of people requesting for this kind of test.
Okay. I think at certain point of time, we may need to include the SARS-CoV inside the panel already because it is
the full panel
there within the population together with other respiratory virus also. Okay.
Right.
Thank you.
Okay, so we have 3 questions. The first one, what does it mean by high and low influenza activity? I think Dr. Hidayah can answer that question.
Okay. The one with regards to the epidemiology, it is basically refers to the prevalence of influenza in the community. So clearly, the data have shown that the number of cases are way far beyond the baseline of influenza cases within the recent, as compared to the previous years even. So in that situation, we are basically in a high activity of influenza infection based on the data. Clear-cut definition for how low is low or how high is high, even the international guideline like IDSA does not provide the exact definition for that.
Okay.
For the rapid kit, post-mortem, this one I never encountered before, but yeah, I know that for the commonly, right, if you go for the molecular, then you can normally test for the post-mortem because it's more sensitive. But I'm not quite sure there are people using rapid kit for the post-mortem sample.
Okay.
Is it because I think the treatment purpose, is it? Because in post-mortem, if it's positive, we don't actually do a contact tracing.
Yeah,
as
I
appropriate, right?
think
This is
that
for SARS-CoV, I think.
I think for post-mortem sample, the sample is very valuable. I will proceed with molecular testing. I won't
Yes.
do antigen in the
Yeah.
first place.
For influenza, it's not quite likely lah, because influenza is not as like SARS-CoV. But previously for SARS-CoV, definitely those who want to go for very you need to go for the postmortem sample, checking whether it's infected by SARS-CoV before they can go what to call very
Yeah, because for the post-mortem sample, basically they need to know the result fast for them to, or if not, or you don't need a specific site of management if the body have influenza, right? Just for you to know the diagnosis lah. Okay.
yes.
Thank you so much.
Molecular test.
All right. And we have the third question from Dr. Mutmainah from ONG. Do we have influenza vaccination program for SASMED staff? So I think this one, if I may answer first, this the vaccination staff for staff for influenza is have yet for SASMED staff, but maybe soon we can propose for our staff, especially in the critical care areas, to have a vaccination. Because one thing about vaccination for influenza is yearly, right, Dr. Hidayah?
Yes.
Yearly.
Yes, it's not like hepatitis B vaccine, which you can use that particular type of vaccine for few years time. But for influenza, the strain is being revised. The strain that is represented inside the vaccine is being revised yearly. But I think for now, the vaccine that we are using is still the same like the previous 1 or 2 years. Or 3 years, I think. They still haven't changed the subtype that the vaccine represent, but still it is subjected to a global surveillance, and they will decide what particular influenza strain that they will include inside the vaccine. Okay.
As of now, actually, I went to KPJ Kuantan to get the shot. They charge around 60 ringgit, I think, per shot. But I asked last week, they already ran out the files. So dah habis. Laku keras lah.
And among healthcare worker, we are recommended to get an influenza shot, because if you are having influenza and you are attending patient, especially high risk patient, there is a risk of transmission. So you don't want to, although you feel like you just okay, just demam sikit-sikit, just fight the patient, tak boleh. Patient are vulnerable and they need to be protected. So we are the first line.
I think they have untuk sekarang ni, I think the supply for vaccine kita ada constraint sikit lah. The next, not in SASMED, I mean like generally in Malaysia, the next delivery will be in September. So untuk August ni memang tak ada. Ni I confirm with the pharmacist in KPJ lah. Not sure in SASMED yet.
So dalam tahun depan ke, Fadi? Dalam tahun depan ke boleh dapat vaksin?
Maybe lepas kita dah settle all this COVID thing.
Okay, sama-sama.
InsyaAllah. Alright, so far tak ada question dekat dalam YouTube stream lagi, and also kita punya chat box. So we already extended about 2 minutes time. So if there's no more any question, I would like to thank to Dr. Hidayah and also Mr. Fu for giving such fruitful re-education, opening eyes info to our services. So insyaAllah, so without further ado, kita tangguh dulu lah dengan bacaan Istighfar dan surat Al-Ikhlas. Alright, thank you so much everyone. Okay, have a nice day. Assalamualaikum.
Thank you.
Okay.